And his public health interests are in global health and international medicine, including bioterrorism and disaster medicine. He also teaches bioethics to healthcare professionals. Dr. Holt is our very distinguished editor of the Southern Medical Journal, which is an internationally recognized Tier 1 journal, and we're very proud of his work and of the journal. He's been presenting this update in his home state of Texas, which I'm sure we all recognize as the beginning spot for us here in the U.S., and we look forward to his comments. Dr. Holt, the Southern Medical Association appreciates you very much for rearranging your schedule last minute to do this for us. Thank you.
Thank you, sir. Appreciate it. Thank you, Dr. Cotter, and thank Dr. Bibbins. That was an excellent presentation. I learned a lot, and I'm going to take back a lot of the lessons that she gave to us. I hope to be able to supplement her presentation to some extent. I'd like to go through with you something about the history, the development of the management of Ebola patients. And as Dr. Bibbins says, it is an evolving thing. Before I came in here at 4 o'clock, I checked my phone just to see what was the latest. And then, if we have time, some of the ethical issues that arise with diseases such as this and the decisions that have to be made by clinicians and others. So you probably know this, but the virus was given its name because of its initial outbreak near the Ebola River. Almost all of these outbreaks, pardon me, I'm going to pull this down just a little bit. Okay. Most of these outbreaks have occurred in jungle areas away from civilization, and just happen to be very close to the Ebola River here at that time it was Zaire Democratic Republic of the Congo. It is a filovirus. There are two species, Ebola and Marburg, and most of the problems that have been caused recently have been of the Zaire type. But you see there are 4 other. Ebola virus is one of only about 30 viruses that can cause a hemorrhagic fever. But at this point in time, it's the one that we typically fear the most because of its very high death rate. And the fact that some of the other subcategories there have either not been seen in humans or their death rate is in the 20 percentile rather than 60 to 80 percentile as this thing develops. The Ivory Coast has had a very high rate, as well as the current Zaire. I guess now about 10,000 people have been affected, and about 5,000 fatalities from that in Western Africa. The problem, of course, is that a good number of those individuals are healthcare workers who have taken care of those particular patients. It's filamentous. Apparently, on electron microscopy, has very easy to identify form, although you rarely see it in specimens unless they're actual tissue specimens from a biopsy. It's not encapsulated, so it could be potentially susceptible to antiviral therapy. Has 2 modes of action depending upon the glycoprotein it produces. There's a small glycoprotein that actually attacks the neutrophil and deactivates it so that we don't have that immediate response to any sort of microbe invasion of our body. There's a second response, and it may well be due to this particular glycoprotein giving rise to a lymphopenia that also affects the patient's ability to fight this infection. One of the larger glycoproteins actually attacks the endothelial cell. And when they die, then the vessel becomes more permeable, and there's internal and external bleeding as a cause of this. And the patients can actually also get DIC from it. Now, it's interesting. There are well-documented cases of asymptomatic infection in Western Africa from this. And the supposition is, and this might be translated to the U.S. experience, is that these individuals, for some reason, had a more intact or more viable immune system, and was able to fight it, resisted the inactivation of the neutrophils and so forth, and these people survived. Once we understand that better, there may be some ways to utilize that information to help with the vaccine or the management of these patients. There is evidence that the fruit bat may be a vector in all of this. They produce guano, and that can be stepped in by all sorts of animals. They track it into the home of the susceptible humans. In some parts of this country, the individuals actually eat what they call bush meat, which can be animals that might have been bitten by the fruit bat. The animal vectors are probably felt to be important, but it's not been proven. And it can occur in non-human primates as well, and forest antelopes. You already know about the bodily fluids. Contact with mucosal surfaces, both of the patient and of the individual who's in contact with that individual, which would be oral cavity, even the conjunctiva of the eye, and certainly other internal apertures. Of note, I think, and some interest, is that this was brought to the attention of the European medical community in 1976, when a Sabena airline pilot located this young virologist, who was 27 at the time, Dr. Pieter Piot in Belgium, and they were blood samples of a nurse nun who had fallen ill down in Zaire. They were glass bottles, and he transported them in a coffee thermos. One of the glass vials apparently had broken, and so there was blood from the patient and glass swimming around in this concoction. And so the virologist was able to fish it out with gloves. Luckily, he didn't get infected, because in Germany, other virologists had looked at the same virus or similar virus in Marburg, Germany, and had come down and died from the infection because of their accidental contact. And that's the Marburg variety of this particular virus. So he looked at it and he said, well, it's not quite the same as the Marburg that we know. Maybe it's a new one. So he volunteered to go down there. As well, there were CDC professionals going from Atlanta to see what was going on down at that time. They found that this particular hospital was using unsterilized needles to inject women who were pregnant. Perhaps about to deliver. He got there, he got sick, but never got bad. So it may have been an influenza, but I don't know if he was ever later tested for Ebola antibodies or not. He is now head of the London School of Hygiene and Tropical Medicine, which is probably the premier public health institution in the world. So in 1976, in Central Africa is really where all of this began to be identified, using tried and true public health tools. They actually quarantined over 250,000 individuals in that jungle area, and they successfully capped that infection, and it died off. They were able to control it through quarantine and other public health measures. It has popped up from time to time, but this outbreak now in the western part, right in this area here, is one that is now, I guess, the worst that has been seen. Several of the countries closed their borders, adjacent borders to these countries, and have had very good success in not bringing that or transferring it across borders. I think recently there was a 5-year-old who died in Mali who had come from Liberia, but closing the borders seemed to have confined these infections to the countries of note. Children rarely get more than their risk is less than 10% of the general population, probably because they're not in a high-risk category. No sexual predilection, but the men who go out in the jungles where they may come across in some fashion the virus, either droppings or eating the bush meat, are high risk. And then, of course, as Dr. Bibbins said, the women take care of these sick people and oftentimes prepare them for burial, and they're at high risk there. Men and women healthcare workers share the same degree of risk. You know about these symptoms and physical signs. They've been all over the newspaper and on the website. The incubation period, for some reason, does not really exceed 21 days, maybe 22 in a small number of cases. It's a bell-shaped curve. The majority of patients will show an infection between about 6 to 8 or 9 days. If it's a more direct inoculation, such as a needle stick, it could be less, just a few days. A little more contact with mucosal surfaces, maybe 8 or 9 days. But I think there's good reason to assume that 21 days is a good cutoff. Although the way they controlled the initial outbreak in '76, they had a 42-day quarantine period, which really halted it very nicely. Later manifestations include facial myasthenia, which is essentially facial paralysis, bleeding from all sorts of sites, from the eyelids, from the oral cavity, nasal. Then it progresses into system failure. This is why some of the patients may need dialysis. They certainly often will need ventilation assistance. They don't have that to any degree in Africa at all. And so this is something that Western medicine can do, but it does bring up increased risks with peritoneal dialysis and going to the operating room or intubating somebody than the usual risk of taking care of a sick patient in a critical care unit. Death usually comes from total system shutdown. Survivors in the U.S., save for one case, Mr. Duncan, have all survived. And the care, of course, was started early. The diagnosis was identified very quickly. But they have long-standing problems, just like any disorder. The last two long-term sequelae, these orchitis and parotitis are resemblance of the mumps virus. Others, the fatigue, poor appetite, resembles a good deal the mononucleosis virus. So these are systemic effects, generalized things that last for a long time in these patients and in other post-viral infections as well. Fortunately, they do recover sufficiently, and several of the survivors have done so, to donate plasma, which is hyperimmune globulins, to other individuals who have been identified with the disease. You know about the diagnosis, high index of suspicion, 2 or 3 questions, as Dr. Bibbins said, will generally settle the question as long as the patient is honest with you. And one thing about being a healthcare professional is that with experience, you get to know when patients are telling you the truth or not. I heard the question about transferring samples. Many states now have their state labs cranked up to do the blood tests for Ebola. Then they're confirmed by the CDC. I know Texas has developed that capability. Most of them are PCRs or ELISA, and so they're usually hand-carried or driven to the state laboratory for rapid diagnosis. The ones to CDC really have to be sent, and I'll show you the box that has to be transported in. It's a pretty big deal to get them packaged up. There have been some patients, of course, who have come by transport. You've seen how they've done the transport, and it's quite an affair in the aircraft, pressurized, but pretty much in their little bubble. We know about the quarantine policies that were started in New York, New Jersey, Illinois. Other states now, including this state, have developed some sort of quarantine policies. The state of Maine has a policy that is now in conflict with the personal wishes of the nurse that is up there now. And as I understand it, she cannot be forced into into quarantine without a judge's order. So we'll see how that plays out over the next day or two. There are some disagreements now between the CDC, the NIH Institute for Infectious Diseases, the federal government, the Department of Defense, and all of these states. And unfortunately, it just leads to a good deal of confusion and rancor that probably interferes with good patient care and good public health principles. And so the CDC feels that they should not be strictly homebound. Other states feel that they should be. And I'm not going to make any judgment about that here today. I think that's something that you should think about certainly on your own. And for healthcare workers, I admire their volunteering. I admire what they've done over there. So they have to use their own good conscience, I think, about what's best for the U.S. population as opposed to what might be their particular wishes. You know that the isolation rooms are really hard to come by. There has to be a lot of training and preparation. In fact, more and more hospitals, as Dr. Bibbins indicated, are being certified. But 1 month ago, there weren't more than 3 or 4 who were capable of handling these things. Now it's increasing. But most community hospitals, I would imagine, are not going to be capable of doing that. And you know about your own hospital, whether you think that could be handled sufficiently or not. As far as physician management, most of the time it's with the early diagnosis, it's hydration because they will third space a lot of fluid and will actually be hypovolemic even though they don't appear to be. Their electrolytes will be out of whack, and for an older individual that could be a problem, with potassium and sodium and so forth. Proper nutrition as well. When possible, if they can get some plasma from a survivor, that is a big help. To my knowledge, current antivirals that we have to treat other viral infections don't seem to be helpful in these individuals. The idea of waste management is really problematic. At least early on, there were some companies that would not pick up this kind of waste, and the hospitals actually had to incinerate the waste. And every time it's transferred from one place to the next, from one person to the next, there's a risk for contamination. And so the smaller the number of contacts and the distance to travel with these wastes, probably the better. Some good research is underway now. There are a lot of things. The ZMAP, which is essentially the human-derived convalescent immune globulins, and there are a lot of people in Africa who have survived and have those convalescent or hyperimmune globulins in their plasma that can be used, but the systems for collecting those in Africa are not very sophisticated, nor are they very plentiful. A lot of other things being considered at this particular time. It's interesting, I learned that a decade ago, scientists from here and Canada really had a great vaccine that was 100% effective in preventing Ebola transmission in non-human primates. And they thought they could produce this vaccine by 2010, 2011, but it never went any further by getting tested on humans. So now it's been rejuvenated, and they're cranking it out, and the FDA has given special permission for human testing, and they're doing this in some places in the U.S. with small number of volunteers, but most of these have not even gone through phase 1 of the FDA trials, but they're trying to get it over to Africa as quickly as they can for a humane exception. Yeah, that's been talked about. Interestingly, from the medical perspective, there seem to be some conditions that exist that actually are very helpful in resisting this intrinsically. Having a good immune system, a good strong immune system, is probably very helpful. So anyone who is immune suppressed would certainly be at risk. And there has been some data that indicated many of the patients who died in Africa had concomitant diseases that affected their immune system, such as hepatitis, HIV, and diabetes, and so forth. So it may be that, and just generally bad health conditions. So it may well be that the healthier one is, the more likely they are going to be able to survive this. The question has been raised whether in the United States, since we as a whole get our influenza vaccines, whether that has some sort of generalized capability to develop our antibodies fairly quickly to another virus, even though it's not specifically the virus that we have been immune against. That's just a thought and concept and not anything that's been pursued at this particular point. In September, this interim guidance came out that Dr. Bibbin referred to, and essentially it said if you kind of gown like you do in an intensive care unit or somebody who's got MRSA or whatever, you'll probably be okay, and that most hospitals in the United States, if they have a room where they can isolate the patients, will be okay. I think that's been proven not to be the case. And so now the guidance is a lot tighter. But at that time, it was felt that, and Dr. Bibbins identified that soap and water, EPA disinfectants, bleach. You've probably seen some of the hazmat suits that are getting sprayed down with dilute bleach because they have to use those suits over and over again. That's about the only way to do it. And diligent cleansing. So I'm afraid that with the first patient in Dallas, the guidelines that the staff were given were inadequate to care for them. I'm going to go on. This is the system. You have to put it in the blood in a sealable bag, and then you wrap it with absorbent material, put it into another watertight, leak-proof bust-proof container, and then pack it in this shipping container, and do your best to find some carrier that will take it to the CDC. Here is the interim guidance that said almost any hospital that can do it. Well, that's not the case. We certainly know that now. If nothing else, good that comes out of this Ebola crisis, I think our country's medical system will have geared up sufficiently in understanding how to care for patients with these highly communicable infectious diseases that will be very helpful in the future with things like Middle Eastern respiratory disease, SARS, et cetera, or any other things that might come up, and God forbid if it's been used as a bioterrorism unit. So I think our mindset is to crank up and become very well educated in how to deal with this sort of thing. So on the left was the interim guidance on personal protective equipment, and this happens to be in an emergency department. That young lady is a resident, one of the first lines of defense along with the nurses, and she has exposed skin, and that's probably what happened to the two nurses at Texas Presbyterian Hospital. On the right is the new guidance where there is somebody to be present the time of donning and doffing these particular suits. And so this new guidance, which just came out a week or so ago, is that there needs to be an on-site manager that's always there watching everything that goes on, preventing things, hopefully, and looking out for accidents and so forth. And also somebody to watch this taking on and off of the gear itself. Triage could be an office, as Dr. Bibbins noted. It could be labor and delivery. It certainly could be first responders, and some of those individuals I think are at risk. And I'm very surprised that it hasn't occurred up until this particular point that a first responder has been exposed and got the virus itself. Transporting that patient is a real issue, even though the scientific evidence either isn't there or indicates that airborne is not likely unless the patient is actively vomiting or coughs after a vomitus. There is some need to have protection, if nothing else, for the mindset of the persons who are around there and seeing what's taking place in these hospital facilities. Yeah, you can get that. So anyway, here it is. Now, I'm a surgeon by trade, and I've been gowning up to the left like that since about 1968. I have some colleagues in orthopedics who do joint replacements, and they gown up almost like that on the right, with kind of junior hazmat suits, you might say. I have operated in a hazmat suit. It's not easy, but it can be done, and this is something that in the military we have been taught to do under various circumstances, whether it be a terrorism event or whether it's been some chemical or other biological warfare sort of thing. Not easy to do, but certainly can be done if necessary. So this is what whoever looks after these folks or transports these folks or even transports their materials and the gowns and everything has to be dressed like. It's a big deal. So again, on the right, typical operating room gear. On the left, what has to be done now. So there's a problem now, and that is all of this stuff is in very short supply. Companies are sold out. Hospitals all across the country are buying thousands and thousands of dollars worth of these things, and so there's a real shortage right now. And so I'm not sure what's going to happen. I hope that this doesn't become an epidemic or a pandemic, so that everyone has a chance to get their act together and get plenty of these things to protect all the healthcare workers in the near future. This is an N95 respirator. I've operated with these on patients with active tuberculosis. They're very effective. They've been tested and really very good. There's the surgical one, which probably is the one that should be worn in these particular circumstances, just a little bit better. And you'll also hear the PAPR, which is the Powered Air Purifying Respirator. It's essentially like a gas mask within that particular hooded thing. Some of them have the power pack that has to be strapped to the back. And that, of course, has to be cleaned down each time. And some of the newer ones now are operated battery or gas operated from a pack around the back of the neck. So it's all intrinsic within itself. It does get hot in there. There's no doubt about it. There are some cooling mechanisms that occur, but at least the ones I've tried out, it has not been fully successful. The boot and shoe covers, very important, must go up almost to the knee, if not higher, because of the scatter and the splashing. Sometimes the patient may not make it to the bathroom or whatever, so there's all kinds of potential for stepping in this stuff. And you can see if you've got it all over you, there has to be a big concern about how to not drag it out. And I think somehow in taking off some of her gear, at least one of the nurses may have brushed up against the skin. It doesn't take much, as I understand, to infect somebody, particularly if it's close to a mucous membrane like the lips. So here are some of the challenges as I see them for our response to Ebola. Do we identify these high-risk people before reaching? And I admire your work with Project Hope, sir, and what you did with them over in Africa. And these are not just the individuals who are healthcare workers, but anyone who comes here. Should they be admitted or not? And that, of course, is a big political question now, which has almost supplanted the scientific or medical issue, certainly. Just how many hospitals can care for it? Can the community hospital in Muleshoe, Texas, take care of a victim? But again, how likely is an exposed person going to end up in a small community? We don't know. It's a risk that really we have no handle on at this particular point. Dr. Bibbins correctly identified the influenza season as an added disadvantage to identifying these folks and trying to get some idea up front before they get too close to everything, whether they have traveled abroad, where have they been, what kind of exposure they've had, and so forth. Again, medical waste disposal is a real problem, and the big hospitals, Emory, Nebraska, that are taking care of these have figured that out, and their experiences are being parlayed now to other major medical centers. Education and training of medical personnel and even non-medical, such as the janitorial or maintenance staff, they have to know how to do all of this thing. Where I'm clinically active now at the Brooke Army Medical Center, over on the Fort Sam Houston side, where they train 5,000 medics a year, using the simulation, the rapid response team of 30 individuals that the DoD stood up just last week has been trained there on the PPE and so forth. And these are people who are pretty smart about all this. They're infectious disease doctors, critical care nurses, laboratory technicians who work with infectious diseases, but they're still going through a very intensive care unit. This team is going to be available to augment a hospital staff in some part of the country. Just 30 of them. They can divide into 2 teams, but at least it's a start, and education and training is a big part of their particular mission. The big public health principle, of course, is to take care of the infection in the countries where it originated. And certainly if we can control it in Western Africa, and then the U.S. and other countries will not really be at risk if we're able to effectively control it in the U.S. As well. Apparently now there are 5 airports that are checking individuals, but you know, it's that the 1 or 2 that slip through, they don't have a fever at the time, they don't properly indicate where they've been and so forth to get into the population. It can continue to trickle along like it has been. Is it possible to use secretions as a bioweapon? I can tell you that there are a lot of people thinking about that, worrying about that, and seeing what needs to be done. This is Southern Medical Association, and for those of you from Texas, you know that the border is very porous, and we have some real concerns about bad guys crossing the border down there, and what might occur in this particular case with Ebola. Whether real or perceived, it still is a concern. Can it mutate? Any virus, I think, I agree with Dr. Bibbins, can mutate. It has not mutated, but then again, it has always been confined within certain areas in Africa to a large extent. When it gets in another country, perhaps the constitution of the individuals in another country might allow it to mutate. We don't know. We always have to keep that certainly in the back of our minds. And I would say population is not panicked, but I think the U.S. population is really concerned by it. I got a call pretty quickly after the patient went into the Texas Presbyterian from my son, who has a small child there in Dallas, and, you know, what are the risks and everything. And I think, you know, education is important. Right now, as I mentioned early on, there are a lot of confusing and contradictory guidelines and thoughts out there, and it would be nice to have one coherent, unified message to not only healthcare workers but to the American public about what's the best thing to do. Lab capabilities are really a problem. Lab technicians are at real risk trying to do the testing to identify whether these folks are infected or not. And in fact, the contingency that the U.S. military is sending to Africa, they feel that the highest risk are to the laboratory folks who draw the blood and process it in those patients there in particular. I don't think the CDC has enough people in a rapid response, and that's probably why the military stood up a group, but there has to be others. You know, if these things start popping up across the country, there are just not enough personnel. One of my concerns here is that the U.S. Public Health Service has not been heard from, essentially. I don't know where they are. You know, we've got a Surgeon General, we've got a big public health service, but where are they? I don't exactly know what's going on with that particular service. Education, of course, and Dr. Bibbins indicated this. We want to avoid stigmatizing the patients, the victims and their families and so forth. This is it's like insurance in Texas. It's a no-fault thing. For the most part, you have to really empathize for those patients and their families, and when doing things, it has to be done with respect and humanity in all that we do. Of course, that's what we try to do when we care for patients, but this has a little different bent to it, and I think we have to be careful not to stigmatize those folks. I've sort of gone through updates. I put this slide in here just in case something popped up, you know, very quickly. And Yeah, I just wanted to mention that there are a lot of ethical challenges, and we saw some of these with the SARS outbreak a few years back, and other things that we have to deal with. And that is it right or wrong to forcibly quarantine high-risk individuals? Healthcare workers who have had a needle stick and then come right back to the United States, considered high risk. How much do we impose upon them? And right now, it's sort of a state-by-state thing. Federal government has pretty lax quarantine. Other states like New Jersey has a very tight quarantine, and a lot in between. And that, sort of flows into the individual rights of that individual versus public health responsibilities and population risks. And that's a delicate balance right now. We're seeing that played out in Maine, where Nurse Hickox is there not wanting to be forcibly quarantined, and yet the state health department and governor feel that it's important to do so. And they've apparently not been able to agree on a compromise at all. So it is an issue. We have to be quite sensitive to individual versus population rights. Now, let's say somebody popped up in your medical center and they told doctors A, B, and C and nurses A, B, and C that they're going to be assigned to care for that patient. Is it ethical for the nurses and doctors to opt out, to say, no, I'm not going to do it? Or is it part of our obligation when we took an oath to care for patients? It's not dissimilar, I think, to healthcare individuals' decision to care for people who have been in a disaster area when they don't know about their own families. I saw this in responding to Katrina and Rita and other hurricanes disasters, that there were healthcare workers who elected to go home and take care of their families to ensure their safety rather than stay around the hospital. This isn't ethical. The guidance is from the AMA that you have an obligation to do so, but it's not a mandatory sort of thing. At least you have an obligation to consider the ethical ramifications of it. Okay, is DNR appropriate on these individuals? And if so, at what point is it appropriate? And what about highly invasive procedures? I alluded to peritoneal dialysis, intubation. What if these individuals get a bowel obstruction while they're being taken care of, intussusception, or they have a collapsed lung? The more invasive, you can't hardly do an operation in one of these isolation units. They'd probably have to take the patient to the OR or set up a special OR that's going to be an isolation kind of an operating room. And then how do you have volunteers for doing that procedure and giving the anesthesia and the circulating nurses and so forth? Right now we have some scarce resources. We don't have all that much hyperimmune globulin from individuals. I mean, they're sort of a few of them are getting sucked dry with their plasmapheresis. And after a while, we may not be able to tap into the small supply that we have. And the other thing that I mentioned was, do we have enough of the hazmat suits, of the special PPEs? If vaccines are developed within a fairly short period of time, who should get them first? And should it be, it's like a bioterrorism event. Most of the resources say that the people who should be treated first would be the first responders, healthcare workers, decision makers in the community. Does that same standard apply in this case? Should healthcare workers be vaccinated first and then other individuals, particularly when there's a scarce supply of the vaccine? And we have to consider end of life with these individuals. Here they are, they're going to die in an isolation room. Is it possible or even good to allow the family to come in, suit up, and be with their loved one during this period of time? I happen to think that's something that ought to be done if the family's willing to do it, and we can do it for them safely. But others may have a different opinion about that. So just the final words, and I'll echo a lot of what Dr. Bibbins said. You need to understand this virus, and knowledge is power. So the more you know about all of this, the better it is for you to prepare yourself, your staff, your hospital, your family, and so forth. And you need to know how to properly use the PPE. Not many folks have had the opportunity to dress in these junior hazmat suits, quite honestly. And so to do it, put them on, take them off, requires a lot of training, quite honestly. And Dr. Bibbins talked very well about that. I said knowledge is power and knowledge is safety. That's real important for us. I mean, I think of the nuclear disaster in Japan. The individuals who ran in to try to control that nuclear leak knew they were going to die. There's no suit that allows you to go into a nuclear reactor and not be bombarded by those rads. And the last thing I'd say is that we have in medicine everyday ethical challenges. Some of them are small, some of them are large. And in caring for these particular patients, we have to always think of what are the ethical responses, and of those that are ethical, which is the most ethical that we can apply to our care of patients with the Ebola virus infection. Thank you very much.